I apologize in advance for my voice. Revista is so damn fun. I have no voice left. So kudos to everyone at the Revista team for putting on a great event. Hope you all have been having a good time. I know we have. Weather's been pretty sweet. For those of us in the East Coast, this is a welcome respite from a foot of ice and cold. But anyway, thanks for braving the early morning session. We actually have a great group up here. I'm gonna let everybody introduce themselves, but the topic today is around ambulatory strategy in an ever-shifting market. I'm not sure, it should always just be shifting. It's always shifting. But that's the discussion. I'm gonna give you a quick background on JLL and myself, and then I'm gonna get right to it with the folks on stage here, let them introduce themselves. But I'm Matt Corson. I'm our US healthcare leader at JLL for leasing advisory in our healthcare business. And I work with hospitals and health systems and medical asset investors in their leasing strategies across the country. The reason I'm up here is because what we think we do a little bit differently is take a data-driven approach to ambulatory strategy and to portfolio optimization. So worked with some of the lovely folks up here in the past and hoping to work with some of you all in the future. So I'm gonna kick it to Kelly to my left to introduce herself, and we'll go down the line.
Good morning, Kelly Knoll with UPMC. I'm Vice President of Construction, Real Estate, and Facilities Operations. You want us to do our whole portfolio scope?
Sure, tell us about your portfolio.
All right, perfect. We have about 42 million square feet of property, 40 plus hospitals, 800 outpatient centers, 8,500 beds across our system. So we cover Pennsylvania, New York, Maryland, soon to be Ohio as well. We also have international locations in Italy, Ireland, and Croatia. What other fun things can I tell you? About $1.2 billion of capital spend annually. I'll leave it there.
Great, thank you. Stephen
Stubbs. I'm with ATK Group. I was formerly with Adventist Health. And like Matt, I'll have to apologize for my voice. Love the conference, but my story is my son. He came over for the weekend and got me sick. So, but anyhow, hopefully you'll be able to hear me okay. So Adventist Health, a system of 23 hospitals on the West Coast, Oregon, Washington, California, and Hawaii. And we have about 400 outpatient clinics where I was formerly. And I was primarily responsible for their regional outpatient strategy and also to the real estate at a corporate level.
Great. Gina?
Gina Weldy. I am Senior Vice President of Administration at Northwestern Medicine in Chicago. Within my division, I have real estate, construction, facilities, security, and emergency management. Northwestern is an 11-hospital system where Northwestern Memorial Hospital is our academic hub. We have about 1,600 beds system-wide, 400 under development right now, and we have 250 sites of care and 38,000 employees. The epicenter of our system is in downtown Chicago, and everything we do is in the state of Illinois.
Great. So we're going to cover a few topics today within the ambulatory strategy framework. I would say number one, we're going to try to tackle how health systems and physician groups are tackling kind of the inpatient versus outpatient capital spend in this financial environment. The second is, where do we see ambulatory growth happening, right, on versus off campus, and why? Some of the capital structures and partnerships that we're seeing out in the market and how to make this growth strategy a reality. And then lessons learned, I think, from 25 to coming into this year that you think are really driving some of that change. I want to start with, actually, Gina. I want to know, I gave all of my panelists here some homework, but what's the most jarring impact that you've felt at Northwestern so far about the One Big Beautiful Bill Act? What's the most jarring impact?
I'm ready for this.
I know you are. I called on you first.
For us, it's very much the changes to the provider tax. Northwestern Memorial Hospital, while an academic medical center, is also the third largest provider of Medicaid in the state of Illinois. And so when you live within a health system in 49 of the 50 states, the way that we are really paying for Medicare is that the federal government is also matching state funding through a provider tax. And the BBB from 2028 to 34 is going to significantly impact that provider tax, which is going to make Medicaid, which is already under reimbursed based on our cost, even more significant for us to overcome. I think if you talk to those within health systems, what they're going to tell you is it's going to make it more and more challenging for Medicaid patients and the underserved to get care, because right now those are distributed in a way that I don't think many outside of healthcare really understand.
Yeah.
So Gina, how do you see that impacting the way you think about your overall portfolio and the way it's balanced across your network?
I don't think, it's a good question. I think we will stay the course while understanding that as we continue to lose funding on Medicaid, we're going to have to find other funding sources to counterbalance that loss. We're never going to stop taking care of Medicaid patients. That's core to our mission. At the same time, in the world of healthcare, and I think this is what you would hear all of our CFOs talk about if they were around a table that sort of trickles down to real estate, we're going to have to continue to find other ways to pay for that care. So in the case of Northwestern, that's an academic medical center, you'll continue to see us double down on the things that only we can do. So we will continue to double down on oncology, neurosciences, transplant, and cardiovascular services. Those are sort of the spaces that people come to an AMC at the most acute level of care, and our surgeons are operating at the top of their license. For us, that starts to counterbalance the impact of those Medicaid changes. However, I think all of us are pivoting in how we do that. It'll also encourage us to continue to take care closer to home in a less expensive environment for the elements of healthcare that don't have to be delivered on our core campuses.
That's great. Thank you, Gina. Kelly, do you want to add anything to that, what you've been seeing in terms of the HR1?
Yeah, I think it's unfair to make us pick one because it is. I mean, as healthcare systems, we're watching all of the impacts of it and trying to figure out which is going to be the most impactful. I think that's the hardest part. But Gina said this, the amount of reimbursement we get from the federal government is 2/3 of our cost. So you have to figure out how you overcome that. I think there's going to be a huge destabilization of the risk pool. We also have a health insurance plan that covers 4 million lives. So you need to understand what's going to happen there, how that's going to change that side of your business. The uninsured number of patients we have to serve. I mean, having Medicaid and Medicare is great. Having no insurance clogs your EDs, causes length of stay to be longer throughout your sites. So we're trying to drive everybody outpatient, but if they show up at your inpatient, they sit in your beds, you fill those volumes. Like you're just at this opposing forces of everything the government's trying to accomplish by reducing the cost of care. The other thing I think that's really important to be thinking about, and whatever we want to call it, the big, beautiful bill, is the funding cuts for research. So NIH and some of those other resources that are fundamental to healthcare, what all of us believe is true in healthcare, how it's directing our patients to seek care, what vaccines you're getting or not getting. But there's a true ripple effect in those decisions in our communities that we're seeing different cases coming in and different things we've not had to deal with in decades. You're also seeing, Gina, you said it, what is the care we deliver that's unique? A lot of transplant, cutting edge research and first time cases. Those funding sources for research have been cut. Those number of cases, those innovations in healthcare are ceasing to exist because of these changes. And the long-term impacts of that are something I don't think any of us can understand or really know the impact of, but it's going to be significant, and our ability to plan and prepare for it is, can we say unprecedented? I think we say that every time. First it was COVID, now it's something else, but it's trying to be prepared for a lot of unknowns, yeah.
Stephen, anything to add to that?
Yeah, I would say for Adventist Health too is that they're the #1 provider of rural health care in California. So that's where the major hit is on the adjustment for that. What we did as a system is really hedged, probably over-hedged as far as the impact to it, because we're such a heavy Medicare provider. So we've taken a lot of retraction, so significant cuts across the system. So what that means is less money for capital improvements and capital growth on that side. So that's where it's impacted us the most. We're not academic, so the other strategy that we're taking a look at is really to focus on primary care. Now, keep in mind, obviously, that is a lot of Medicaid patients. In the same sense, it's what we're going to need to grow to feed our specialists and the surgeries. So we have to be very concentrated as far as where our strategic growth is. So where we can grow as a non-academic medical center because we don't get that additional funding. So that's going to be general surgeries, orthopedics, and the refocus too on outpatient. So going into where the community is, as mentioned. So growing those outpatient centers, growing the primary care as feeders back into the mothership.
So we're hearing a lot about, we're going to shift right now a little bit to the capital spend side of things, and I'm going to start with Kelly here, but setting the table, we're hearing a lot about outpatient. We're talking a lot about outpatient, reaching the patients where they are, closer to home, lower cost of care environment, lower cost of construction, hopefully. But we read the paper every day and see new towers going up. So there's capital being spent on campus too. So I want all three of you to think about that in this sort of question around capital allocation and kind of what your construction spend priorities are. If you've got one bucket of money, how are you as a system thinking about the best way to deploy that capital? Is it the area of greatest need for deferred maintenance and general upkeep of certain facilities, or is it based on the level of acuity or the revenue, downstream revenue from it? How are you thinking about that? I'm going to start with you, Kelly. Give us your thoughts on that inpatient versus outpatient split, and then how you allocate the dollars.
Yeah, this is where I get out my crystal ball and sort of
Yes.
take a wild guess at these things. No, if we look at our $1.2 billion of capital spend a year, I just looked at our numbers from last year, so 25% of that went to just IT. We're doing a major implementation of a single application of Epic, so all of our 40 hospitals, 800 outpatient centers going to a single Epic application. And you think, holy crap, that's a lot of money going that direction over the next 5 years, but that actually allows us to have more access to data and utilization to do some of these other things that are important to overall business. So once we get IT out of there, another 40% of our capital annually right now is going into hospitals. So though we're trying to drive patients out, we have that huge infrastructure need. We're building a $1.4 billion patient tower right now on our largest campus. That's all replacement beds, no new beds, so 636 new beds for $1.4 billion. That finishes next year, actually a year from now, we'll see first patients. Then the rest of that is infrastructure investments. We do have a focused allocation on just facilities infrastructure, or deferred capital if you want to call it that. But our deferred capital number is so significant, there's no possible way you can take it all on. So then the question goes to what is the overall organizational strategy and where are we serving our patients? Our ASCs have become more important prioritizing the infrastructure because we're trying to drive more patients there. At the same time, balancing the operational needs, so how our clinical teams are actually providing care, rather than just doing it how we're doing it in the hospital. We're trying to change those whole models. From our system, because I have facilities, construction, and real estate, we also have a central command center that we're tying all of those assets to. So we're able to monitor remotely and hopefully avoid catastrophic failures. But because we're putting more patients in ASCs, those are beating out some of our hospitals in prioritization. So I think that answered your question.
It certainly did. Gina, it's your turn.
So we have about $4 billion in active construction right now. That'll all deliver in the next 5 years. Of that, probably 60% of it is inpatient facilities, and the rest of it is outpatient infrastructure. And we have a very structured refurbishment program. We fundamentally believe that we will be in the assets that we're in very long term. I think that's what lots of folks see in the market. Once healthcare providers come in, it's very unusual for us to pull out of the investment. We spend a lot of upfront time deciding where that asset should be because it is so capital intensive for us to relocate. So we do have a very active refurbishment program to make sure that it all keeps up. I think we're having to be very disciplined though around that spend. So of that $4 billion, as I said, much of it is in beds right now. Our downtown campus, we have a $2 billion program underway right now that will most visibly add a bed tower with a pretty significant consolidation of our oncology program. However, we will also go into our existing buildings and basically recover the space that is vacated as we consolidate. We're a little unique in that we are already in individual patient rooms. So all of our room adds in this facility will be net new beds. But we will then go into the outpatient spaces that we vacate, and we will very rapidly flip them for other specialties. However, we do continue to believe that we will never try to accommodate in our owned portfolio downtown or on any of our campuses all of our space. What we know is that patients want to see their doctor for many things where they live and work. And so we're very much making sure that we are moving primary care into a distributed model. With that, there are a lot of care services that really go better in those assets. And so for us, it's everything from things like dermatology and cardiology, now all the way up through cancer care. So you might want to go to one of our core campuses to have your procedure. But then when you're actually going in to have chemo every week, you don't really want to have to drive downtown or drive to a core campus and monkey with the parking. It's so much easier to walk to a neighborhood building or drive into that facility. So I think we will continue to see care get distributed further and further into the community. I think the counterbalance for all of us to that is how are we being reimbursed for that care? And we're not going to make moves into the community that undercut our ability to get reimbursed for the same type of care.
And Kelly mentioned ASCs being a particular focus. Do you have one specific facility type that's in that kind of fastball down the middle for you?
We do not do a lot of ASCs. It's not really core to our model. Our typical community play is anywhere from 40 to 120,000 square feet, depending on the community. We own the majority of those new builds simply because when our CFO and I sit down to have our very spirited conversation, because he always thinks it's a great idea for us to use somebody else's money. One of my lessons learned is I just kind of wait for the numbers to come in, and he sees the property taxes and self-resolves that maybe owning is a better idea, which continues to be the challenge. However, often we can't get the real estate that we want. And so number one for us is always location, location, location. And so if someone is bringing us a site that we know is sort of core to where we want to be, we're comfortable using third-party development as long as they'll meet our building requirements.
And if you're not going to own the asset, are there specific types of transaction structures that you tend to gravitate towards? I mean, are you out there considering all the different creative financing structures, CTLs, SLBs, anything like that? Or is it straight, we're either going to buy it or we're going to lease it?
We're super boring. We continue to look at it. We continue to think many of those vehicles are interesting, albeit our question is always, so who's making money where? I think us understanding that is always fundamental, and I think over the last couple of years we've gotten a better understanding of how some of those may work for us in the future. However, typically by the time the site's brought to us, we're usually just going into a lease with options to get control of that asset in a transaction.
Okay, so Kelly, talk a little bit about, we heard on campus versus off campus, but is there one clinical modality that you're seeing that is just, the cost of it is just way above the others, and you're having to really divert more capital to that actual project, but because it's core to your mission or core to your strategy, you have to invest more dollars in that? Is there something that's just tipping the scales for you in terms of services?
I don't think there's any one service. It's really the transition to ASCs and the regulations between what we call an ASC, an actual freestanding ASC versus hospital-based. And that's a huge dissemination that needs to be done. We use those words interchangeably, or oftentimes in conversations with developers and brokers, they're used independent or interchangeably. The cost of building a freestanding ASC is extreme. There's no way you can make the math work. You cannot put enough specialties in there. You can't have enough throughput. You can't have enough pre-post PACU rooms to actually make money. So if anybody can solve that equation for us, I'm glad to talk. I'll have a whole bunch of projects for you. But the reality is we're trying to figure out how to reuse other spaces, how we're trying to take a Burlington coat factory, take a Toys R Us, and turn them into freestanding ASCs. But most of our ASCs are actually hospital-based right now. We have 3 actual freestanding ASCs, and we'll have 6 or 7 in the next 2 years.
So you're seeing the cost of ground-up construction for those ASCs being prohibitive?
Absolutely prohibitive.
But an adaptive reuse, you can make it pencil?
I still don't think it pencils, but we're probably going to proceed with those. I think we'll proceed with our ASCs as well. The math is just extremely hard to make happen. And I don't know what everybody's seeing in their market, but when these major data centers, we were talking about this at breakfast, we don't have a lot of labor in the market, just enough union workers to build buildings. The cost of labor is rising, I'll say exponentially, some curve that's not helpful to match the reimbursement rates. Then you have a data center hit your market or anywhere close to your market, it gobbles up all the labor, and we are trying to compete for labor, but we can't pay them any more money, right? Like we have set costs. It's a no-win scenario. Another one that I'll take, if somebody has a solution to this, we just can't figure out how to do it. So when you can reuse a building, you can just reduce some of that labor force, which overall helps with your capital commitment. Speed to market, though, is the other thing. So some of those reuse make a lot more sense if we can get in the market sooner.
Stephen, talk about, you mentioned primary care, right? Yep. It's something you focused on before. What were you seeing when it comes to the costs to build those out? Many of those were probably not ground up, right? Those are, you're fitting out, either former office space or you're repurposing other clinical space. But talk about the cost allocation of how you're building out the clinics that were drivers for you.
Yeah, so it's adaptive reuse, just especially in the Los Angeles market where I'm primarily based at, but even some of our other markets too, is that the cost is just prohibitive for us to do any de novo projects on that side. So, and it's very geographic focused. So we're really looking at markets where we're growing is that where the population is going to support that. So that's with the limited capital dollars, and also one of the things we're also talking about too at breakfast was in regards to the haves and the have-nots. So on the West Coast right now, there are a lot of systems that are doing really good. There's really focused on growth. There's several systems that are back retrenching, and I mentioned, Adventist Health too is just retrenching. So with the limited capital dollars we have to be very focused on where those are going to go. So it's not a global strategy for the entire system. It's wherever the markets are doing, and right now, quite honestly, we're having to focus on where the hospitals are being profitable. So if those hospitals are being profitable and there's some population growth that's happening, those are the markets that we're going to be going into. So Los Angeles is a very tough market for us right now because there's so much competition with the academics. And that was the other thing too that I've noticed in the Southern California market especially, is the academics are gaining more and more market share year after year at a scale that I've never seen before in my entire career. So, so it's very limited to the competition factors that we have and where there's the opportunities in those markets, but it's really up to the population growth. So I would say much more concentrated strategy than a CEO who has a certain emotions like, oh, I want to, I saw this open site as I was driving home from work and I want to build something there. So that's just not, those days are not happening anymore.
So we're going to stay on the topic of site selection here because I think this is important for everyone here to learn a little bit more about. But other than population growth, which is sort of table stakes, I'm going to start with Gina. What are some of the drivers for you when it comes to picking the right location? So we all get it. Sometimes the tail is wagging the dog. The real estate site is the driver because you just know you want to be at Main and Main, right? But if you're not just being brought a site that someone's got on their top of their list for Northwestern, what factors are you using to find the pockets of opportunity in your ambulatory market for new sites or a relocated, consolidated site?
Sure. So I would actually tell you it is extremely rare that someone just brings us a site and we say, great, this is a really cool place, we're doing it. I don't think I've ever done one of those.
You don't want to get 150 emails after this panel?
Yeah, that's not usually, I always am very gracious. I'm always more than happy to receive those locations. I always send them along to our team to plot on the map and very quickly can get an answer on whether it's even in the strike zone. So we have a really, really rigorous, robust process to determine site location. I work very, very closely with our chief strategist and her team. Our teams have a really, really solid relationship, and our data analytics go pretty deep. We actually start with our strategy data. First cut is where our existing patients live and where our employees live. When you have 38,000 employees and you're self-insured, you are definitely going to understand your employee base and where they live. So that's kind of first cut. Second cut of that is what are they coming to us for? And understanding what of that is outpatient and what of that ultimately converts to an inpatient stay and where are they going for that inpatient stay. Once our strategy team, and they use lots of data tools to do that work, in addition to our own systems, they then are looking at patient data throughout our market. We then do a soft handoff, and our real estate team is sort of coupling all of that patient data with what we all know to be true in the real estate world. So where are patients shopping? How are communities changing? So we're looking at median income. We're looking at population growth. We are looking at average ages. We are looking at cell phone data and how folks are traveling in and out of what I'd call the core zip codes that strategy has identified, because often strategy is identifying where people live. Real estate has to identify how that area trades, because you're not going to drop 100,000 square feet of medical into the middle of a neighborhood. So all of those pieces come together to ultimately identify what I would call our hot zones. Sometimes it then becomes a pretty smooth process to find real estate in those hot zones. Usually it doesn't, because we still want turns in and out of the site to go the way that we want to. We want zoning to not be an impossible hurdle. We are very big on, from the time we get the real estate to the time we're opening that building, has to be fast, because that's one of our hedges on construction costs. It's speed from time of allocation to time of first patient day. So by the time we are actually taking down a site, it's probably been a pretty long process. Those moments that we end up going into what I'd call a significant lease, and our building in Oak Brook is an example of that. We knew already where we wanted to be. We had identified 5 geographies where we wanted to be. We were watching those geographies. We were trying to do land acquisition in some of those geographies, and this particular asset location popped. It was exactly where we wanted it to be. It was exactly what we wanted it to do from a pace to opening. And so sort of the stars aligned. In those cases, we're very quick to move down a path. But the amount of work we've already done, I mean, we already have, I've got two sites in for capital this year. We haven't even gone to market on the geographies, because at this point, if I don't have basic sight line to capital, it's not worth sending teams into the market, because sites transact too fast. I don't want to be in the market until I know I can get control. And money's kind of core to that.
Your team probably appreciates you not making them run around the market for wild goose chases. I would appreciate that. Thank you. Kelly, talk a little bit about the same thing for you all. What are your priorities when it comes to, I'm sure there was some overlap there, but is there some, you know what, we find our patients have to be close to a Starbucks, or we know that some of these sites have to be at, controlled intersections, or is there something about the site selection and the data-driven process for you that you find unique?
I think the most unique thing is that we're in markets that are not growing. So population growth will help drive that decision. If you are not seeing growth, you're just trying to steal your competitors a portion of their business. And for 1 or 2% of their business, it's quite a heavy lift. So as you're moving people from inpatient to outpatient, you have to figure out how you're backfilling, and that's that market share. So it's a balance between all of those dynamics and triangulating. We are trying to get closer to the people. We're looking at the Starbucks. We're looking at all the same data as Gina just went over. Some of our communities, Pittsburgh, City of Bridges, we're looking at bridges and tunnels, which is an embarrassing data set to figure out. But people don't cross them and won't go through them to come to get care, which again, as you consolidate, and if you just put the data on a map, it seems crazy that we would have some of these sites so close, miles-wise, but it's 20, 30, 40 minutes to get between them because of a bridge or a tunnel. So that's probably the one unique thing that most people don't really understand. It's hard to put that data into the calculations.
Yeah, that's psychographic data is big.
Yeah, absolutely.
Stephen, expand on that a little bit from the non-health system perspective when it comes to ambulatory strategies, right? And whether it's clinical rollouts or it's consolidations, what are some of the factors beyond the economics that you see as drivers?
Right now, the main factor is really ensuring that business is going to drive growth to the hospital, and it's going to drive profitable growth. Because one of the things that, especially with getting back to HR1, Big Beautiful Bill, is that there's now specialties that just simply before COVID, during COVID, would be able to provide money to us. So there were big strategies to try to get and honestly to compete with the academics. Those hadn't worked out so much. So and it's going to be very hospital specific too, and very system specific. So what their core, what their core practice is and what their core specialty is. So it's going to round back to the primary care and those basic services where reimbursement's going to be very good. So that's probably the most primary thing that they have to take a look at. Is where are we going to be able to get profitable reimbursement for those strategies to go into it.
Talk a little bit, staying on you, Stephen, talk a little bit about the M&A of practices and how that kind of feeds and folds into the overall strategy.
Yeah, so that's really important as far as being able to acquire those practices where, because it's going to be less expensive to acquire a practice or to acquire a building or to acquire something, especially in the outpatient field for us too. So it's a less expensive play because they already have the infrastructure. They have employees that we can acquire too. They're going to have the contracts that we want also too. So that's going to be a big driver going forward for the systems, especially in the area, in Southern California area. Because it's the most important thing is to take a look at how the reimbursement plays out.
Gina, how about for you with M&A? You own your docs, yeah? Mm-hmm. So how often is the acquisition of practices on your list of priorities when it comes to, entering new markets or just expansion around what you have?
Sure. So M&A, right now we're doing less, we're not looking for hospitals per se. However, as we bring a new hospital merger in, actually our South region, we still have a lot of work to do. That's a region that, when we go into a market and go through a merger, it is atypical for many hospitals to have the employed physician base that we have and prefer. And so typically one of the first things we are looking to do is really stabilize the base and ensure that the physicians that are serving the facility and serving the market are aligned with our clinical protocols and our expectations. And so we do a fair amount of, I'm going to call it hiring. However, much of it does look like mergers in that, or acquisitions, in that it is private physicians. Some have practices that we really are bringing into Northwestern medicine in order to employ them. Often there's more than just the physician that comes with that. So it is pretty typical as we are going through a larger hospital integration within a region.
Kelly, do you think about the acquisition of a practice or a doctor as one step in the process of growth, or is it purely just opportunistic for you?
I think it's both, but one of our site locations comes down to non-competes. So we have very few actual competitors. You know what the general compete language is. So as we're acquiring individual docs, we're thinking about where can our next clinic be that's close enough in a market, but outside of their non-compete range. And that's quite an analytics from a real estate perspective to be doing when you're just not actually sourcing the patients. You're trying to source where your doctors can be working. They come with a lot of unique deals, though. A lot of these acquisitions of practices have, I'll just leave it at unique. It's stories for the bar to talk about what comes with some of those deals. So they're always a lot more than what meets the eye on those, especially on the real estate side.
I would also say, one thing that you don't hear all of us talk about as much are dispositions. But I actually think, at least in my case, we are doing a lot more dispositions than we have done in as long as I've been at Northwestern in my 20 years. Often health systems have land that comes with a merger on the balance sheet. And it's farmland, or it's, oh, we really thought we were going to have a building there, but it's kind of on the wrong side of the highway now. And the market has shifted, and now we're sitting on 10 acres that's really attractive to someone other than us, but we just have kept it. We have the little building that we still have a couple docks in, but we're building 100,000 square feet, half a mile away. And so we are actually much more active in the disposition space than we've ever been. We don't need to keep that land on our balance sheets, and we all need to find sort of sources of income right now. So I would say, at least for us in the efficiency space, we have, I've got someone who's almost full-time working on some dispositions right now to sort of get these properties into the hands of folks that would like to have them and can make more of them than we can.
And would you prefer usually to just get out scot-free and monetize? So
yeah, we had one particular deal that we had the opportunity to be an investor in it.
Yeah.
On paper, we actually would have ended up, it was probably, in the real estate lens, it was a very safe deal, very well-capitalized developer. We could have contributed our land to a much larger development and had a really nice income play. But we're a not-for-profit, we're not a real estate company, and it's not what we do. So at the end of the day, typically, we would prefer to just exit the property through a clean path. I think that's very much our internal strategy. That may differ with different health systems.
I think we're the same. As we're trying to figure out new revenue sources, our real estate teams are like, hey, we can do this play,
Totally.
We can bring some money in. But from an organizational perspective, it's just not worth the time and effort to do those things. We're also disposing of all these houses.
Yeah.
You guys know the strategy 20 years ago. You buy every house around the hospital and you hope it's worth $1 bazillion when the hospital wants to expand. We're generally not expanding most of those campuses, so a lot of houses around hospitals if anybody wants a small, poorly maintained house.
I've sold
near
a few
hospital
real good
campus.
houses lately, too.
So.
A lot of helicopter ambulance noise, too.
I would say, though, for the tight markets, the deep urban markets we have acquired, only because you're just stuck. You have to. It's still less expensive to try to rezone those projects and everything like that, because eventually you're going to have to grow the space. So we do the dispositions, but it's usually where we're just given random property that somebody gives us. But for the most part, it's still part of our strategy to acquire the surrounding property around the hospital.
Talk a little bit about, it's pretty obvious that, disposing of land or surplus non-core real estate is accretive to the bottom line, and you can generate usually good dollars doing that. But talk a little bit more about, I'll start with you, Kelly, about existing off-campus sites and thinking about adaptability for future uses. How are you investing in those spaces? Because they may have been built for one purpose 20 years ago, but now the market's shifted, the dynamics have shifted, the service lines have shifted. So now we want it to be something else. How much of your investment dollars go to doing that, which is a smaller, further downstream kind of bottom line impact, but you know that you need to kind of adapt your facilities to meet your patient demand. So talk about how you think about that today.
Yeah, anything we're building, we're renovating, we're trying to keep flexible for future. We've done a pretty good job making our spaces flexible and adaptable. And today's answer to any of our clinicians or physician leaders when they want to adapt space is, can you do it for $0? And that's the bottom line. Otherwise, those projects are not getting approved. The capital is simply too impactful to the organization, takes too long, closing a site for some amount of time, none of those things align with the business. So the first strategy is use it as is state, no dollars, and then if there's a business impact that's positive and you want to make the next step, we might support it.
Gina, what about you?
Fitness centers are the bane of my existence. Legacy Northwestern Memorial Hospital never got into the fitness business, but a lot of people did. And those are some really big facilities, and I have studied the life out of them, and they are not cheap to convert. So that's probably the category that I have in our portfolio that I just am shaking my head on right now. So if somebody has a really good adaptive reuse and is interested in picking up a fitness center in a suburban market, I'm all ears. Most of our other space, we are pretty comfortable in the adaptive reuse category. I would tell you that's the category that saves us rather frequently. I think the shifting retail market has proven a win for healthcare because we've been able to go in and pick up good locations pretty reasonably. You can take a building in a strip mall and reskin it, and it looks just lovely when we're done. We also, on our core campuses, office space conversions to medical office, as long as the elevator situation in the building doesn't break us, which it does sometimes, that's typically a slam dunk conversion for us. We can do it fast, we can do it cost effectively, and we can do it sort of within space that we're already paying for. So I think we've made a big push, and again, this is the efficiency play in converting office space that we already controlled into clinic space. So I do think the adaptive reuse is alive and well. I think much of it almost appears invisible because if the walls are there and the infrastructure is there, converting it saves us all money.
Okay, we're going to shift a little bit to some external pressures facing all three of you. I'll start with you, Stephen. Talk about, well, there's a lot. We could spend all day talking about external pressures, but let's focus on construction costs, tariffs. Is that a nothing burger, or is that something?
Well, it's one of the things that we already talked about was staffing. You know, trying to work with the contractors to and then time to market too. So those are probably the biggest things that we have. The tariffs, you know, obviously it's going to affect us all equally as far as that goes. I think the pressure that it puts is that really as far as on the RFPs that you're putting out with the contractors. So that's probably even more acute. So whereas you'd love to keep everybody that you have relationships with, it really comes down to who's going to give you, honestly. And we used to always look at value. So you looked at, you have the good relationships with your GCs and your contractors, but now it really came down to, you know, loved working with you, but at this point it's all about the bottom line, unfortunately. So I think that's the dynamic that's really changed, is that you may be changing contractors continuously because you're just kind of chasing whichever one is the cheapest, which strategically we know is not the smartest. And we were talking about this in our group yesterday, is that, you know, now we're having to, everything's short-term thinking. So everything now is really short-term. What's the next strategy that we're going to have to do? It used to be, so there's no long-term strategy that we're having to kind of play out for. It's all short-term. So, you know, for lack of a better answer, there's a lot of factors that are included in that, but it really is coming down to trying to manage those costs as best as you can and going for the cheapest dollar, which like I say, we're just operating in a short-term strategy mode right now.
Gina, how about for you? External pressures that you're dealing with that are...
Yeah, we've all seen construction costs, right? So I won't belabor that. The escalation since the pandemic has been sort of astounding. I think our strategy in hedging those is our speed. And so I think what we've discovered in sort of our construction domain is the faster we can get a building from funding to open, it's the best we can do to hedge against the construction costs we're seeing. The tariffs, I think it's going to be years until we all get the data that shows us exactly what the impact of tariffs is. There's no way it's not affecting us. I do also know I'm very blessed with a really strong internal construction team. I have watched them working with our GCs and our subs to do some pivoting around where we are sourcing things from, because in long lead items and really big buys, simply changing where the materials are coming from in some cases is producing lower costs for us. And so I think we've been opportunistic with that. But I do think, we look at what we're all sort of living with in the construction domain. But as Steve said, much of that is really driven by the headwinds that we are financially seeing within healthcare overall, and sort of the counterbalancing that our CFOs are all doing to ensure that there's capital available to allocate. Because at the end of the day, we're not for profits, but we're not for profits because we're not paying investors. We have a very, very capital intensive business. Equipment is so expensive. Our medical records, Epic is a very, very important tool to patients. It's the reason that health systems have grown. You can go to that doctor by home, and when you end up in our emergency room downtown, or when you end up with a specialist, you don't have to go back through everything. You don't need to get your records transferred. Your tests are all in this, it's all there for you. That is a very expensive system to operate and to invest in. And so I think you're seeing us all sort of do a lot of pivoting because of the financial headwinds we've seen from both the federal government, but at least in the case of Illinois, the state changes have been just as impactful for us. And we know we have to survive the headwinds sort of without sacrificing the long-term journey, because we're all here for 100 years.
And you mentioned Epic, and that's one thing is that Adventist Health did take a look at that. And it was over, and this is what affects our construction dollars too. Mm-hmm. It was over, they expect over about 10 years, there's going to be $1 billion invested just into the EMR, and that's a conversion.
Wow.
So, that's where the pressures are. So, it's good that you bring that up because we're talking about tariffs, construction costs and everything like that, but it's simply operating costs that are draining our capital funds for things like the EMR. So that's a big factor too. So I'm glad you brought that up.
Yeah, I'm very careful to break out our IT component of our construction projects, because without doing that, it makes our construction numbers per square foot look like health systems totally overspend when they build their own buildings. Well, it's because we include our IT spend, and our IT spend and our equipment spend is, I agree, astounding. However, in order to put Epic in place, which we all consider core, for those of us that rely on it to every site of care, it's just a big number. I think our security numbers are the other number that we now have that are much higher than what a typical developer puts in place. It is no longer good enough in the world of healthcare to lock the front door. Even at our off-sites, our teams they're just not willing to work in that environment. And I think the employee satisfaction pushback has become so significant that our security numbers kind of continue to grow in our construction numbers.
So give me a number. What per foot are you seeing on security?
I don't have that for you right now, mostly because for us, it's not a perfect per foot.
Okay.
Because the baseline infrastructure in some cases is the same, whether it's a smaller site or a larger site.
Right.
And that Epic and security infrastructure sort of overall bandwidth has to be sized together. But we are doing, we're looking at everything from, our camera systems are phenomenal. That's going to solve the problem after the fact. We've always had sort of the panic buttons in one location. I think we've seen those increase. And then the cost to support an issue in a site has gone up. I could give it to you after. I haven't looked at it recently, but that wrapped up IT security spend is significant.
I mean, it's huge. Every building, especially hospitals, we're putting mags and evolves at every entrance, and then you need at least 3 FTEs to maintain them because of workplace violence. Gina, you said the outpatient sites. We're going through this whole effort with 800 sites. I get an email every day from somebody who had a patient come in screaming, yelling, threatening physical violence, and they may have a toggle bolt to separate them from the front to back of house. So we're going back to all of those outpatient sites and figuring out how you create physical separation that might buy somebody a few moments of time. It's a really scary part of construction and design, though, right now, to put safe rooms or lockable rooms in every single site where people can be secure. We don't talk about this because it's not perfect. You're chasing it. You're trying to make your people feel safer every single day. There's no single solution, but it is part of every single construction project, part of our cost that's inherited into everything we're doing.
Yes.
It's concerning.
We've added weapons detection to our downtown emergency department. Really, the cost to operate a single location with weapons detection, with the staffing and the capabilities to take and store weapons that may or may not go back to patients, is almost $2 million per entry. And that's one entrance. And that's absorbed in operating expenses. That's not even the capital costs to ensure that you've got enough physical distance between the point of entry where they're being scanned to the point of entry into the facility. We've now gone through, we're starting to close entrances into buildings. So we have a very public set of buildings. We've always wanted to embrace the hospitality philosophy. I think now we are hospitality through less doors.
But what Gina's talking about, you wonder where our capital goes. When you have a campus that has 75 entrances, and you are trying to get all of your FTEs through one or two, it's back to COVID days, but now you're trying to screen them and get everybody to work, and your parking structure all over. We spend a tremendous amount of time trying to figure out that effort, then redirecting all of your patients, re-signing your campuses for access. Do you make your cancer patients go from what was the cancer entrance on your hospital campus halfway around the building to come into one of the two entries? That's not a patient satisfier, but that's how you balance safety for your employees. It's a every single day, every single minute conversation that we're spending a lot of money on.
As you're thinking about developing for health systems, do be thoughtful about how you're building, how security does wrap into it. How are folks going from parking spaces into buildings? Don't do big, lovely reception areas that are big circles anymore that I used to do all the time. Do a lovely, tight, they can see every entry point and every visible piece of that lobby with their back to a lovely wall where they're behind a snug little desk that keeps them safe back there but has room for all their technology. Thinking about how the building is positioned in a larger development so that you are balancing the walk distances of patients now that we're doing less entry points does become significant. It does sort of change the base floor plate and the shape of the building that many of us are looking for. And as you go up into the building, we're probably going to think, we think about elevator controls differently. I don't want everybody to just go wherever in a building. I just want them to be able to hit certain buttons at certain times. And even when you get up on the floors, we're probably going to be looking for a way to still completely secure that building at night, which is not necessarily something we did in the past. So I definitely think as you're approaching health systems with potential development, thinking about safety is much more at the forefront these days.
Let's stay on that. So we're getting close to time here. Kelly, I want you to give some advice to the audience on ways they can work with you or approach you or talk to you. And you only have to say it once because everyone's here. You don't have to send that all.
I've been waiting all day for this question. No, I think we say it all the time. We, as leaders in our systems, talk about this, like really understand our business at the core. We're talking about the headwinds. We just went down a rabbit hole on safety and security. That was not on any of these talking points.
No.
But if you understand what we actually do and navigate through the course of the day, and I know everybody's like, we get it, we get your business. Like, I don't mean to be rude, but I really don't think people fully understand between access, between changing how payments are happening, between security, but like every single event that every single day is coming across our desks. If you understand that, you will understand how our decision making is so sporadic, why it seems like we can't make decisions because these headwinds change direction every single minute of every single day. The closer you can get to understanding that, I'm here, bring unique solutions because what we used to solve these problems in the past does not hold anymore. It does not work. And unless we have creative solutions that get us into markets quicker, get us more cost-effective solutions, we just can't make it pencil.
Good. Stephen?
Yeah, I mean, it's very similar to what Kelly shared, and I think the key point is to really understand, and it's going to be back to what I mentioned earlier as far as the geographies, because different geographies, urban, rural, will have different pressures, and to understand what those are in the different states. Every state will have certain requirements, even, and you're going to have your local people that understand that too. But different counties have different requirements too. In one county, it'll be very easy to do certain construction projects based on zoning. Other counties will have other requirements, so it makes it very difficult for healthcare. Parking, of course, we all know about that. But I think it's really echoing what Kelly said as far as really understanding not just the real estate piece, but how the operations function within a facility for that. So it's all the components that we mentioned today as far as, and so what's so important, the pressures right now is the reimbursements, because we're constantly looking at less and less dollars almost every year. Unless things change in legislation, at least for the next several years, we're going to be faced more higher costs and lower reimbursement.
Okay, so I'm going to synthesize our takeaways from today. I want to thank my esteemed panelists here. You guys did a great job. Hopefully everyone in the audience learned a little something. Number one, reimbursements down, construction costs up. Terrible, terrible, terrible ratio. Adaptive reuse is alive and well, I think we heard. Speed to market is critically important, always has been, but is especially important today. Balancing operational efficiency and patient safety and employee safety and patient access. That's really kind of a seesaw, right? So we want to get that as balanced as we can. And then IT spend is a little bit of a surprise for some people here, maybe that's a big needle mover for you all and something to manage. And when you're contacting these lovely people, keep in mind, they're probably dealing with someone driving their car through the front door of their hospital, right?
That was 3 weeks ago.
That was 3 weeks ago, sorry. There's probably been 10 more challenges since then. But anyway, I want to give everyone a chance to do one quick closing thought, and then we're going to wrap up. I'm going to start with Gina. One closing thought. You've got 30 seconds.
My closing thought is thank you all. You keep us educated and nimble on the real estate market and the healthcare real estate market. You bring us data tools. You bring us lenses that you are seeing that helps us synthesize what we do internally in the outside market. So I think continue to do that, recognizing that we will also continue to be managing a shifting business that may be a little different today than it was yesterday.
Yeah, it's still important is, I don't want to sound dour up here as like, everything's falling apart. There's still going to be opportunities. Outpatient's still going to be, a major driver, and it needs to be. As far as where reimbursement's shifting, more codes are changing every year, more to ASCs. So there's still plenty of opportunities. And I do want to reemphasize, what Gina mentioned as far as the partnerships. The real estate folks, they're smart, they're strategically focused. That's what we need to kind of level set. We get sometimes too much into the weeds. So we do need that help as far as to really see where the growth opportunities are and to really be a partner, in helping that system grow.
Kelly?
At the end of the day, I think we all need to sort of ground ourselves in what we do. We have the privilege to serve communities and change lives. I would just remind you that that's what our focus is every single day, no matter how hard it is or how horrible we just shared our days are. We each strive really hard to remember why we do our work, and when we're having those conversations, it's helpful if you guys can remember who's at the end of those conversations and decisions every single day. We will ask hard things, we will push for hard things because we need to deliver more care to more people who are sicker and in worse conditions every single day. So thank you for the partnership and thanks for the ideas.
And thank all of you. Appreciate it.